Hi, I'm Dr. Lowery with Injury Care Centers, and today we're looking at neck adjustments. So we're going to discuss the mechanics behind adjusting the neck. We talked earlier about that the neck is really divided up into three regions. You have upper cervical, mid cervical, and lower cervical. So with the upper cervical, typically we adjust in, it can be a seated position or a lying position. But the upper cervical spine is going to handle more of the neurologically based issues. It's also going to handle things like headaches, vertigo, trigeminal neuralgia, anything that initiates from the upper cervical region. So with upper cervical, we're dealing with the occiput so the occiput sits on top of the atlas. The atlas is there's no disc between the atlas and the occiput, and there's no disc under it. So the atlas can kind of move lateral, okay? It can rotate, so it can move different ways to support the head, and that misalignment can cause headaches and referrals up into the occipital region. So a lot of times the patient will complain of pain that radiates to the back of the head, headaches that come up in the back here or to the side. Also jaw alignment, TMJ type things will be affected, and that also can be adjusted in front of the occipital area. So depending on what the patient presents with, the adjustment will determine what their presentation is. So with the patient here, we're going to work more of the upper cervical region. So one of the ways to check, I check for rotation. He's already moving. So if he's limited with rotation, I know that that's going to be upper cervical. Okay. If he is limited with flexion and extension, that's going to be mid cervical. Okay. If he's laterally flexed limited, that's going to be lower cervical. So with the patient, he has a little bit of restriction when I rotate his head to the right. So I'm going to adjust his head, adjust his neck by rotating his head to the left. So what I would do is I'll make an upper cervical contact with my hand, support his head, and at the same time, I'm going to lift up a little bit. There we go. So it's just an easy traction of his neck and then rotation. And that way I don't have to use that much force, because you want to use just enough force to make the adjustment. All right, so now he has a freer range of motion with his rotation. All right. I'm going to check the mid-cervical spine for his facets. So with the mid-cervical, we talked earlier about your facet joints. So the facet joints handle the weight, the disc in the front, the facets in the back. So with a mid-cervical adjustment, we want the center of your spine to move forward. If you'll hand me that model there. So with the mid-cervical spine in this position, we want to facilitate more of an anterior motion to unlock the facets. So by unlocking the facets in this part of your spine, the neck can reset in from a straightened position to more of a curved position. So we're going to work with that, and that's the type of adjustment I'm going to do now. So I palpate on the neck to find out where there's restrictions, because the neck should have a spongy feel to it. When you push on a joint, it should move in segments. So when I feel restrictions and I palpate, I notice that there's one segment that is not moving compared to the next. Okay, so that's the one I'm going to want to adjust. So when my adjustment is going to be from a posterior to an anterior type position with a little bit of rotation. So when I again palpate, I hold the head. Okay, so he was upper cervical on the right, mid cervical on the left side, and then I go back and palpate and recheck. And sure enough, he's got good movement. Did that take some of the pressure off? Yes? Okay. All right. Now there's, before I turn him face down to address the lower cervical, you see a lot of patients, you see a lot of doctors, they will use what they call an axial pull, okay? You'll see a towel maneuver where they wrap it around the neck and then they just pull on the whole spine and just take it and jerk. I don't do that type of motion because I feel like you lose control of specifically where it adjusts. I like to keep my adjustments very specific, not that that's a bad thing, but I do that axial pull, but I do it with my hands so that I want to control it. So I don't want to lose control of my pressure. So what I'll do is I'll contact the spine just at the lower part of the cervical region, and I just do a little bit of a pull up, and then it's just a quick, just little pop. Now, he'll feel it more mid-back or mid to lower back. So it's not going to have the same type of audible as you would see when you wrap a towel around and just pull, but that's okay. That's not what I'm looking for. So that'll help with some of the compression because the facets on both sides can be compressed. And if they're both compressed, they put pressure on the disc. So to take that disc pressure off, when you do an axial decompression, it'll take the facet pressure off and then reset. So if you hit it from all three perspectives, then your neck is going to respond to that. All right, so now we're going to address the lower cervical. So I'm going to have him turn over face down. So we've already addressed the upper cervical, the mid cervical. We did a little axial decompression. So for this adjustment for the spine, we're going to go with the lower part of the neck. So we're dealing more with the lateral aspect to the neck. So I want to adjust from C5 through T1, T2. And how I do that is I do a lateral type motion. So for the patient in the face down position, and for patients that are afraid of rotation, some patients don't like their head rotated. They don't like that type of feeling. So patients that don't like that rotation, I will use this and I can adjust all the way up to the occiput. But for this specific demonstration, I'm looking at more lower cervical, okay? So I want to enhance between T3 and we'll say C6, roughly in that area. So I'm checking for fixations, so I'm palpating, always palpating to see where you don't feel the normal type sponginess in the spine itself. You can do a palpation with range of motion. You can do a motion palpation. All right, so for this adjustment, I'm going to adjust him on the right side. So what I'm going to do is I'm going to laterally flex his head, okay, to the left as I push down on his shoulder to the right, and that's going to give him a lower cervical adjustment, okay? So relax. Good. Now it moved nicely. I don't know if you could hear that or not, but it moved nicely up into the upper back, into the neck. I'm going to check this side just because it feels like it's restricted. Again, I've got a point of contact, so I'm holding it there. I'm lateral flexion. There we go. Nice release. So that's going to take away the upper thoracic, lower cervical distortions, and that thoraco-cervical interjunction right there. That is a huge component of movement in the neck. Okay, go ahead and sit up for me. Sit up facing that way. So anytime we do any type of adjustment, we always like to kind of do palpate to see how it's doing. So we're going to check the range of motion. Turn your head to the left. Good. Turn to the right. Nice. All right, look straight ahead. So now we're going to laterally flex, bend to the right. Good. Now bend to the left. All right, good. Look straight ahead. All right, now I want you to bend your head back. Good, and bend forward. All right, good. All right, relax. All right, so we've cleared out upper cervical, mid cervical, and lower cervical. So now his neck is going to reset into a more anatomically correct position. All right, so we're going to continue this type of adjustments, and if that doesn't handle the pain, he's not having radicular pain, then we would do an MRI to see if there's any disc involvement or any further trauma. And that's it today. Thank you.